Good morning once again. Welcome everyone to the National Symposium on Cornea. And this year we are talking about the current updates and the new modalities that are available in cornea in the past couple of years. So I'd like to also invite the chair for this session, Dr. Samar Basa, co-chair Dr. Geeta Iyer, please come to the dais, convener Dr. Anil Radhakrishnan, and co-convener Dr. Vinay Pillai, and Dr. Manisha Acharya if she's here. All right. So we'll start off we'll start this talk with our opening batsman. And we have a very strong lineup anyway, right from the last batswoman is a very strong lineup. So Dr. Kuresh Maskati, I think he kind of needs no introduction.
Yeah, we'll keep it that way.
Okay. He's going to, and thanks for accepting the talk at short notice. He's going to talk about the new corneal drug delivery systems.
So if we close the doors so that no one can leave, because this is a dry topic, things which are so new that even I have not heard of them before preparing for this talk. Okay, so we are aware of the problems that we have in the ocular surface, that we have a hydrophilic surface, so it welcomes things which are hydrophilic, but most of our drugs are hydrophobic, the effective ones anyway. So we need to ensure that the drugs reach the ocular surface and get into the epithelial cells. And various polymers have been found. So these are some polymers which are called mucoadhesive polymers. So they come and stick very well, and they have enough time because they are there, so they can slowly elute their contents. They're biodegradable and non-biodegradable. You get two types. The importance of whatever polymer you're using should have a good viscosity and adherence value, and a reduction in the drug drainage rate. The drug should not drain too fast. And some of these drug carriers, they attach themselves, they have a mucin coat outside, so that the mucin layer will love them, hold them in place, and then it can slowly, so it improves their residence time and establishes a contact between the drug and the tissue. Some of the newer polymers with unpronounceable names are the ones which you can read. I won't delve into the details because you will forget them 30 seconds after this slide moves. Then you have medicated contact lenses. This has been around for some time. They can provide a controlled or sustained release of medication. So in theory, it sounds very nice. And you have now nanoparticle laden lenses. Lenses with nano is really a new buzzword in drug delivery systems. We'll hear a lot of nano in the next 6 minutes. So these are biomimetic and imprinted contact lenses with layered structures, causing an extended drug delivery along with improved availability and reduced side effects. So if you have a contact lens which elutes the drug, then you need about 80%, 20% less to achieve the same effect. Then you have ophthalmic inserts. Now this was tried decades ago. I remember those lacquer certs which came in, and it fell out of favor because they were irritant and the dissolving rate was unpredictable. So now there are some newer ones in the pipeline which are non-irritant, non-toxic, and actually effective as well. And they use polymers like polyacrylamide and the one which we are familiar with, which is PVP. Then the other one which has been around for a couple of decades is iontophoresis. So it can be transcorneal or transscleral. A weak electric current is used with a ground electrode somewhere in the body. However, it's never come out of the research labs because of several disadvantages. You can get epithelial edema, burns, you're using an electric current, damage at the site of the application. And you can't push drugs which have a larger size. So you need those with low molecular weight, small drugs, small size drugs. And then we come to as I said, the new buzzword, which is nano. I always thought that nano means small and that was the only thing. Only when I was researching for this, I found that there are different, nano is also, there are many variations in nano. So let's try and make it a little simpler. The size of different nano formulations is usually below 1000 nanometers, fabricated through chemical process. So this is common to all nano formulations to release their therapeutic agents and to enhance penetration. Major advantage of utilizing nano carriers is it improves the bioavailability, and it achieves a controlled release and a targeted delivery. So you can decide where the drug is going to reach and then deliver. So they offer higher drug retention time, lower dosage requirements. In other words, they seem to be just the perfect things for us. How does it work? The cornea and the conjunctiva possess negative surface charges, and that enhances the retention time of any positively charged nanoparticle. So if you can create a nanoparticle which is positively charged, the cornea conjunctiva being negative will hold it more efficiently than those which are anionic, and therefore it will give an increased opportunity for the drug to enter. So the first one I'm talking about are nanomicelles. These are amphiphilic. I learned this as a new term. Amphiphilic means hydrophobic and hydrophilic at the same time. Very small, 10 to 100 nanometers in size. Now these nanomicelles consist of a hydrophobic core. For example, cyclosporin drug is a hydrophobic core, and the drug is confined in that hydrophobic area, but it has a hydrophilic tail which protrudes to the outside environment. So you can see that these are micelles and micellar emulsions. So nano emulsions, now the variation nano emulsions are thermodynamically stable, little larger, 10 to 1000 nanometers, interfacial surfactant layer separating the oil and the water. So these drug carriers can be oil in water, water in oil, or a continuous spectrum, and they allow the entrapment of hydrophilic and lipophilic drug particles both. So hydrophilic and hydrophobic, which is lipophilic, can both be incorporated if it's a nano emulsion. Then you have nano capsules. Nano capsule is something like the Sequa, which is just being launched by one of the companies. The drug is enclosed inside a protective matrix with a size which is very, very small, 10 nanometers. The drug is now entrapped inside, it's adsorbed or dissolved into the matrix system. It improves the bioavailability. So there is an outer coating, something like an orange fruit. So you got the coating outside and the active drug which is inside. The amount of drug required is very small in these cases. So what happens is that this capsule, then when it reaches the ocular, it's hydrophilic, so it goes right down to the ocular surface, the epithelium, and then that capsule, if you again imagine the orange fruit, the capsule just dissolves or disintegrates over there as if like a programmed time bomb, and the micelles which are inside, which are hydrophobic, can penetrate the epithelium and cause their desired effects. Then there is a variation called dendrimers, which are symmetrically shaped nanoparticles, and they have a hollow core which encapsulates the drug. So this is a dendrimer has a core which holds the drug into place, and you can either enclose the lipophilic. See, lipophilic is the issue. You want that lipophilic moiety to go down. So you have a hydrophobic cavity, you have this lipophilic material which is inside, and the drug is attached to this hollow core, the dendrimer. So you can see that. Then you have hydrogels. Hydrogels are highly absorbable natural or synthetic polymers as a three-dimensional framework. The flexibility is achieved by providing sufficient water there. When they're exposed, the three-dimensional cross-links render these structures ordinarily insoluble in water when used in topical formulations. Therefore, they adhere to the mucus. There is good mucoadhesiveness, and it increases the residence times. New words for us: neosomes. Neosomes are prepared by self-assembling the hydrated non-ionic surfactant molecules to form bilayers. So 2 layers. Medication is encapsulated. Again, the whole principle is the same. You have 2 layers. Medication is encapsulated inside a vesicle surrounded by the bilayer. So it's a non-ionic surfactant. I told you there were 2 types. You could have an anionic, positive and negative, but you can also have a non-ionic like this, cholesterol and a charge-inducing molecule. So various ophthalmic drugs are being tried by some of this, and the first cousin from the mother side of the neosomes are the proneosomes. They are free-flowing, which on hydration become the multilamellar neosomes. So it's basically like a pro-drug thing. Why does it work? Because it improves the shelf life of the loaded moiety. So I have tried to encapsulate my talk on newer drug delivery systems, and whatever I understood, which is about 60% of this talk, I have tried to make you understand. Hopefully about 30% has gone in. The important thing to remember is that it is difficult to give talks like this, but it is difficult for the drugs to penetrate with our, no matter what the pharma companies tell you, to achieve penetration. So they all tell you about how the micro emulsions, and we've got nanoparticles. And now we know that nano doesn't mean nano. There is lots of varieties even in the nano. And we are still far away from achieving the optimal drug delivery system. That means you put a drop there and it goes straight to the optic nerve and stimulates it so that no more optic atrophy. So we are nowhere near that zone yet, but we are trying to see that at least drugs can penetrate through the tear film that we have and reach at least the epithelium and retain there and stay there for some time so as to achieve their effects. Thank you so much for your attention.
Thank you very much, Dr. Maskati. I think, as usual, you made this topic easier than it sounds. Just I had one quick question about the neosomes and the other nanoparticles that they retain for a longer time. But do they achieve? Can they achieve the dose that is required, the concentration that is required?
They're doing a lot of work on both the neosomes and the proneosomes, and the initial results are encouraging. That the first prototypes which were there were not able to achieve the concentrations, but the newer ones which are coming in, they're improving the retention time and the concentrations that they want. Yeah. So I think they will be the future. I think the dendrimers and all will go, and we'll be left with the nanomicelles and the neosomes and the proneosomes. Yeah, thanks.
Yeah, so for the practical use of clinicians, I think we have nano tears that is available. Then the cephalosporin, which is which is quite popular as restasis, which is an emulsion, and now we have the sequoia. What is the difference in the
Yeah, you see, nano just means small. So if a particle size is less than 1000 nm, it's called a nanoparticle. Now you can have a nano micellar thing. That means a drug which is with a tail. You can have the sequa type, which has got a outer coating which protects it while it goes in. You can have just the fact that it's a nano emulsion. That means it's very small particles in an emulsion. So there are variations in nano, and everyone just tries to promote that ours is a nano. Even the nepafenac type of drugs, that ours is a microfine emulsion, and then the words are used interchangeably. His is a microfine emulsion, mine is a nano emulsion. So it doesn't really mean, and nano just refers to particle size. In nano, you can have, as I said, emulsions, micelles. So you need to go a little deeper into how exactly it is doing its work. Thanks.
Thank you, sir. I don't know how better this can be presented. Thanks a lot. Now we have the next talk by Dr. Sayan Basu. He'll be giving us an update on ocular surface, or rather the first update on ocular surface of the day.
Thank you, Vinay. Good morning, everyone. So I thought instead of doing something very fancy, I'll keep it a little bit relatable and clinical, and talk about what is our new approach or way of thinking managing symblepharon, and how we are doing it in the clinic nowadays in cases with limbal stem cell deficiency, and addressing this 360-degree as a why, when, what, and how. And I hope that all of you will find the talk useful or actual practical management of symblepharon in the clinic, because this is really something that is very common, but also not something that is really talked about or discussed or explained in a lot of detail in existing literature or in textbooks. So when you think of why and when, I think you think about managing a symblepharon when it is threatening the visual axis or starting to affect vision. It might start to affect vision just by causing astigmatism. When you're planning to do this along with ocular surface reconstruction, when you're planning to do this to facilitate scleral contact lens fitting or to improve cosmesis, and also to facilitate cataract or intraocular surgery. And I'll explain how in each of these scenarios we go about managing symblepharon and what and how. So you have essentially to manage symblepharon, you basically have three options. You can either use an amniotic membrane graft. The amniotic membrane is a good scaffold. It by itself is not tissue that lasts forever. So if you use amniotic membrane to address symblepharon, it really doesn't last for very long. It lasts between 6 to 12 weeks, and therefore it carries a very high chance of recurrence. Conjunctival autograft is the most physiological replacement for symblepharon. It has the best long-term recurrence-free survival rates and also provides the best cosmesis. So definitely in unilateral cases, you're thinking of using a conjunctival autograft. However, it's not always possible because you might have bilateral issues where you can't harvest a conjunctival autograft from the other eye. Sometimes you can even take it from another part of the same eye, but again, depending on the severity of the pathology, it may not always be possible. And then you always have the option of taking it from the mouth, which may be from the lip or from the buccal mucosa. So these are mucous membrane grafts. These are also good autologous substitutes for the conjunctiva, and especially in bilateral cases where redundant conjunctiva is unavailable, either from the same eye or from the other eye, this is a fantastic alternative. So how do you put these two aspects together? So if you're looking at addressing this problem where you are doing it for addressing the visual axis being threatened along with ocular surface reconstruction, etc. Like I said, the best option is when it is unilateral using a conjunctival autograft, when it is bilateral using a labial mucous membrane graft. But when you are doing it only to facilitate cataract surgery or for implanting a keratoprosthesis, you can maybe get away with an amniotic membrane graft. Or if you're looking for more permanent way to address the issue, then you plan to do a conjunctival or a mucous membrane graft. So, like in this case, there is involvement of visual axis in affecting vision because you have a symblepharon like a pseudopterygium which is approaching or inferiorly and threatening to involve the visual axis. So in this case, actually, what we have seen is that limbal stem cell transplantation is not required because you have so much of limbus that is already spared superiorly. So you can get very good outcomes in these cases by just doing an adequate conjunctival autograft, which gives the best outcomes. And you can actually harvest the conjunctival autograft even from the superior unaffected conjunctiva and get outcomes which look like this. This is the same case with a ipsilateral conjunctival autograft done from the same eye. And 1 year post-operatively, you can see that the eye looks practically normal. And we have also shown that over a period of time, conjunctival autografts do best for these kind of cases of pseudopterygium with symblepharon rather than attempting to do an limbal stem cell transplantation using SLET or any other technique, because it's unnecessary. You have unaffected limbus superiority, which is enough. And you might also want to address the symblepharon when you're doing it along with ocular surface reconstruction. So this is a case of total limbal stem cell deficiency following a chemical burn. You can see that there is a very severe symblepharon superiorly, which is extending from the palpebral conjunctiva onto the corneal surface. So this has a high chance of recurrence even if you do a successful SLET or any other form of limbal stem cell transplantation, and therefore this needs to be addressed. And if this is addressed properly, then you can get a very good functional and anatomic outcome at the in the long term. You can see here that a SLET has been done to address the limbal deficiency on the corneal surface, and a conjunctival autograft. You can see the margins over here. The conjunctival autograft has been done to address the symblepharon in the superionasal quadrant, and with this you can get very good outcomes. Some more severe cases. This is a case of rheumatoid arthritis with severe pseudopterygia and limbal stem cell deficiency, addressed by doing a SLET and also a 360-degree conjunctival autograft to address the symblepharon. Another case of extensive tuna burn where you can see that the conjunctiva is almost lost 360 degree, all the eyelids are completely stuck together to the cornea, and reconstructed again with SLET and conjunctival autograft to give a very good functional and anatomical outcome. You can see 360 degree, the patient can now move the eye and the conjunctival redundancy has been restored to a large extent. More severe case where the same thing has been done. Here you can see multiple failed attempts to do ocular surface reconstruction, then successfully rehabilitated by doing a SLET and an extensive 360-degree conjunctival autograft. So the technique essentially is, after you release the pannus, you harvest the conjunctival graft along with the limbal tissue, and we basically split the conjunctival grafts into thin pieces. It's important to give limbal coverage, not so important to give bulbar coverage. So you want the peripheral tissue to stop short of the cornea. It is not important to, like you when you do a pterygium surgery, to completely restore the conjunctival redundancy using only that graft. And after completion of that, you carry on as you amniotic membrane graft on top, and then complete your slit surgery by putting the pieces. And this usually will give you very good outcomes. The limbal transplant will take care of the cornea, and the conjunctival transplant will take care of the symblepharon. And sometimes for improving cosmesis, this is the patient with SJS with a severe symblepharon with the upper lid stuck to the corneal surface. Here with a mucous membrane graft, because it's SJS and bilateral, reconstructed, and the patient is wearing scleral lenses 2100, 2080 vision, and with better cosmesis. So now the worse eye, which he was unable to open earlier, is now the patient's better eye. Again, a very similar case of SJS, the upper lid stuck to the cornea, released, reconstructed with a mucous membrane graft and with with a slit-like procedure using the ocular surface graft. Again, very good functional and cosmetic outcome. Patient sees 20/60 in this eye through with scleral lenses. To facilitate cataract surgery, which is another indication that I mentioned, where you have extensive symblephra like this, but otherwise the view and is good, you can carry out routine phacoemulsification in these cases. Here you would release all the symblephra in this case from the corneal surface, and then carry out your procedure, just being extra cautious for doing surgery in a case which has a little bit of you know inadequate visualization. But you carry out the surgery in the same way, suture all the wounds because the peripheral cornea may be thin, and at the end of surgery, because you know that the central cornea mostly is spare and the patient will anyways recover good vision, you use a amniotic membrane graft to address the conjunctival deficiency after completing your cataract surgery, and that is usually enough and gives good outcomes. And in very severe cases where you can't use conjunctiva or amniotic membrane, like this is a case of pemphigoid, one-eyed patient, the other is no light perception, this is the only eye, and patient has a brunescent cataract. So here it's very, very difficult because doing a cataract surgery now is going to be very risky. So first you have to address the symblepharon, create some space so that you can do cataract surgery later, which is technically easier, and also rehabilitate the patient with scleral lenses. So you also want to create the space where the patient can wear scleral lenses so that you can have optimal visual recovery. So basically, the amniotic, the mucous membrane graft is used similar to a conjunctival graft, sutured superiorly and inferiorly. And after this is the second stage of the surgery, where about 3 months later we are doing cataract surgery again. Like I told you, very advanced cataract in a one-eyed patient. We don't want to do something more aggressive like a keratoprosthesis. And it's because you've already restored the conjunctival redundancy, you can carry out a normal cataract surgery. Here you can see the brown cataract that we have removed, and then now the view improves a little bit and we put an intraocular lens, and this is the same patient with scleral lenses later, now seeing 2200, but this 2200 vision is probably going to last the patient the entire lifetime. So all of these procedures that I've described, this is a QR code that you can scan, and this gives you access to all the videos that I have on SLED, on MMG, on ocular surface reconstruction, keratoprosthesis that you might find useful, and you can access this at any time, and I keep updating this file so you can see it later and see what new things we are doing, and use this for your learning and also for your reference anytime in the future. So just to conclude, um, for severe cases, if it's unilateral, we use a conjunctival autograft, bilateral, we use a mucous membrane graft, and where you're just using it for a temporizing measure to carry out a cataract surgery, etc., you can either use an amniotic membrane graft, or you can do these procedures if you're looking for a more permanent effect. Thank you so much. I just want to thank my team, which, the work that we do is contributed by a lot of people. We have more than 40 people in our group, and also want to thank my family whose time I'm borrowing to be over here. Thank you so much.
Thank you, Sam, for the nice crisp talk. Next, I would like to call upon Dr. Namrata Sharma for her talk on artificial cornea.
So thank you. Should I start? So thank you. I would be talking to you about the biosynthetic cornea that we are working on. And this has become important because we know, as per the recent survey, corneal opacity is the second commonest cause of blindness in our country after cataract. And in the age group 0 to 49 years, it is the commonest cause of blindness in our country. So, would just like to begin with the corneal ectasias, where you do lamellar keratoplasty. In some of the cases, can be really tricky, and this is just a prelude to show that suturing in these cases may be a little difficult. Uh, for instance, if you see in this case here, if you have to suture the periphery, then you have to go right till the periphery over here, tuck the graft in, and if it is excessively thinned out, then this can be a little problem. We do require 2 lakh corneas. We collect only 52,000, transplant 25,000. So there is a huge disparity between what we collect and what we transplant. Possibly we don't even have the numbers of exactly how much we need. And in the COVID times, it did decrease further, and we've still not come to the level where we were in the pre-COVID era. So there is a need for biosynthetic cornea. The limitations of human donor cornea are limited supply of the donor cornea, risk of graft rejection, post-op complications associated with sutures and wound healing, risk of corneal neovascularization and or infection, astigmatism after suture removal, need for long-term topical steroids, and necessity for long-term patient follow-up. The biosynthetic material that we worked on is a bioengineered porcine construct, double cross-linked. It is a clinical grade collagen type 1, and it has been cross-linked using cross-linking agents. And basically, this is how it looks. And it is quite transparent, something like a soft contact lens. It comes in 12 millimeter diameter and varying thickness from 100 to 500 microns, and has a shelf life in the bottle for 2 years. It has undergone all the quality check tests that are required, like optical and mechanical properties, enzymatic degradation, in vitro cell bioavailability, end stage UVC radiation sterilization, biological safety, shelf life stability test, as well as in vivo biocompatibility test and ex vivo analysis in mini pig keratoconus model. So we look at the transmission, and here it is comparing the two. One is the biosynthetic porcine construct, and other is the biosynthetic porcine construct, which is doubly cross-linked, as well as the human cornea. So it is light transmission is almost the same as that of the human cornea. And if we compare the scanning electron microscopy, it will show tightly packed collagen fibrils in the BPCDX cornea, with the slightly thicker fibrils as compared to the native porcine corneas, as can be seen here. Subsequently, if you see the epithelial adhesion, the control here is a plastic on which the epithelial cell adhesion is being evaluated in BPCDX. The adhesion is quite good, and there is greater cell density than the cell culture plastic ware. In the animal studies, again, this has been compared with the autograft, and it does compare very well with the autograft when we compare it with the BPCDX, both in terms of pachymetry as well as in terms of corneal curvatures, and also in terms of the confocal microscopy. And also this is to show animal study of the autograft. So this is the native, this is the autograft, and this is the BPCDX, the epithelium and the stroma. Again, you can see that in the immunohistochemical analysis, the subbasal nerves by beta 3 tubulin marker show preserved stromal nerve in the BPCDX cornea. And this is how the surgery is done. There is nothing too much to it, except that you do require a femtosecond laser to make a pocket. And once this pocket is made, this can be opened up with the help of the lamellar dissected, and this is how it comes. So you have to triphinate it according to the size of the pocket that has been made, and either one can just place it, or if you made a smaller incision, then just fold it like we used to do the older lenses, which used to be folded with the forceps, and just then unfold it inside and place a bandage contact lens. You do have a little bit of corneal edema in the first post-operative day, which subsides over a period of time. This is another case of keratoconus with pellucid marginal degeneration, where the thinning is there very much in the periphery, and there is also a cataract which is there along with it. So in this case, again, the femtosecond laser is being used to make the pocket. And you can go right up to the edge and right up to the periphery here. The offset that you have to keep is about 120 microns at the of the recipient, so that if it is more, then there are chances that the laser may not fire adequately. And then this case was subsequently taken up on the intraop OCT microscope. Again, this pocket which was created was reinforced with the help of the lamellar dissector. And then the biosynthetic cornea was placed inside after measuring its size. And because this patient also had a cataract, so 3 months down the line, the cataract surgery was also done. And it is quite clear, and you can do the surgery very well, except the rim that is there, which is seen, it otherwise is quite clear, and there is no problem in visualization. Now this is again the case 2, and you can see the sandwich biosynthetic cornea inside, which is present intrastromally. This is the third case, again very severe keratoconus. So when you do put a intrastomal synthetic cornea, there might be some folds which may be there in the immediate post-op period, which over a period of time do become all right. And this is just to show the same case, Kmax of 85.9 diopters and post-op Kmax of 57.1 diopters, and it has become a in regular pattern as well. And this is our longest follow-up, so all you see is this rim which is there, and otherwise it remains quite clear. Now very recently we've used this also for a case of post-LASIK ectasia, and this is the case in which the flap is elevated, and after elevating the flap, what is done is the biosynthetic cornea is placed. Notice that it is so thinned out, the recipient bed, and possibly that is why ectasia has been caused. The pocket is again reinforced all around, just we've described tuck-in lamellar keratoplasty for these cases. And after doing this, the biosynthetic cornea is placed, and you can see how thin out the bed is, and possibly that is why this ectasia has occurred. In this case, you can't leave it unsutured, you have to suture it because the flap becomes edematous, and after suturing it, one can again place a bandage contact lens. Now this is in the post-op period, and notice again it is so thinned out, the bed is so thinned out, and this is again a Kmax of 89 dropped down to 50.4, and pachymetry of 241 increased to 581 microns. So sometimes you can have situations like this where you can't use a femtosecond to make the pocket, but you can use a microkeratome to dissect it, and if it is hazy, you may even have to address it manually. This is the biosynthetic again cornea, which is being placed after triphinating it into the correct size, and then all you have to do is just glue it, and after gluing it, one can place a bandage contact lens. I like to always put a reverse put the bandage contact lens in a reverse manner, because I feel that gives a little tighter fit, and after doing this, this is the post-op picture. These cases do take a lot more time to epithelize. It takes about 7 to 10 days to epithelize, because it has to epithelize on the onto the synthetic cornea, but over a period of time it remains quite stable. So these are our results. Now we've done in 50 plus corneas, and all patients had good visual acuity with no rejection, inflammation, vascularization or scarring in any of the patients, and the mean pachymetry increased from this was actually done in 2 cohorts, one in Iran and one here. So the mean pachymetry improved in both the cohorts, and Kmax also showed a decrease of 11 diopters in Iranian and 13 diopters in the Indian cohort, with the best corrected visual acuity, which was quite good. And these are the results which were arrived at 48 months. Now, if you look at the epithelium and the confoscan pictures above and below it, then they appear to be quite normal, and this is too far-fetched. We are not going to get rid of eye-bank corneas, but this is one step towards it. Possibly may not require, if we are able to grow endothelial cells on this, all this paraphernalia. So there is a feasibility of distributing these corneas. It is potentially safe and simple surgical procedure, not dependent on human donation, no graft rejection, suture-related problems. And it does not preclude a human graft transplant if required. And what I think reality is going to be complete corneal construct. This was just the stromal construct when you could grow endothelial cells on them, which again is a very difficult task. This results of this study were published in Nature Biotechnology, both the Iranian cohort as well as where the impact factor is 68.1. So to conclude, use of bioengineered corneas for intrastromal keratoplasty is feasible, safe and simple technique. Of course, we do require longer follow-up, and a larger number of cases and maybe more variety of cases is required to conclusively say so. So this is just to show how, just like intraocular lenses, you put them and you use them from the wrap. I hope something like this happens to the corneas also in the near future. My acknowledgements to our collaborators in Sweden and Tehran with whom we've been working, and thank you very much for your kind attention.
Thank you, madam. One question. The last case which you showed, where you did an ALTK, the graft or the artificial cornea, was it fixed with sutures or just glue?
It was glued.
Just
it was not fixed with sutures. Suturing this cornea is very difficult. It cheese wires, and to pass a suture is difficult. Then for the sutures to stay there is difficult. So as of now, you can only glue it or put it intrastromally.
Subsequently, you've also noticed that the biosynthetic cornea gets populated with the cells in postoperatively.
It remains acellular essentially. Over it, you can see that the cells are there. I mean, on the confocal scan, we could pick up the cells and the nerves. Below it, and the endothelial cells could be seen. But if you see, even in the animal studies, when you compare it with the autograft, it remains acellular. There are no cells in it or nerves in it.
And what's been the longest follow-up? I'm sorry, I'm not
So
sure.
the longest follow-up is now 6 years.
If I can ask a question. Dr. Namrata, fantastic, mind-blowing work. The only question that comes to my mind is I had this when something similar was presented by the LVP group also, that normally in an eye bank, we don't use each and every corneal tissue. There is always some amount of, subclinical tissue or, suboptimal tissue that we do not use. And if COVID has taught us anything, it is not to waste tissue. At that time, we used to glycerol preserve it, make it acellular, and, diversify the usage. And suppose we adopt such a very stringent principle of not wasting any tissue at all, and those which are not optimal for surgery, we all the time decellularize it with glycerol or any other means, then wouldn't it be just would we really need a stromal construct after that?
So it would depend on what you decellularize it with it. If you do it in glycerine, like glycerine preserved corneas, then of course those corneas are very thick and you would possibly have to split them. And I don't know whether they are clear or not, because they are not going to be clear. I think they are going to be opacified. So that is a challenge. I think you can do it with anything, but then at least that material has to remain clear.
So the fineness of tissue is better with this than
this is clear. It is acellular, just like your glycerine preserved cornea, but it is clear, so the patient sees through it.
Right.
Thank you, madam.
Thank you. Thank you.
Next, we have Dr. Umang Mathur here. No, I think. So next I would ask Dr. Sumita Chaurasi to come up and give a talk on endothelial implants.
So good morning, everyone, and hello all. As my topic is artificial endoimplant in the management of corneal edema as an alternative to DSEC and DMEC. The current standard procedures for the management of corneal edema has been utilizing the human donor cornea, and there are 3 types of transplants, PK, DSEC, and DMEC, which we use in different case scenarios with excellent outcomes. And we all are aware of the limitations of human donor cornea, which is there's a risk of graft rejection, failure. Tissue can harbor infectious agents, some of which are known and unknown. There is a need for steroids, and there's a risk of steroid-related complications. And also the fourth issue is the availability of suitable donor corneas. We are all aware of this world map, which shows that some supply and demand disparity of corneal transplantation in 148 countries, and we know there's a global shortage of donor corneas, and hence the interest in the alternative measures of management. The various options in evolution are the endothelial cultures and cell-based therapy, because with this therapy, we can, with one donor cornea, eight patients requiring transplants can be treated. The second is the use of biosynthetic devices, which is the artificial endo implant I'm going to be talking about. So this device comes from the Ion Medical, Israel, which also manufactures the Hyperseal, which is already in use. And this is their team, which comprises of the team which is based in Israel and US, and the advisory board, which is of scientific committee of corneal surgeons as well. So the initial study started in the animal model, and initial results were in rabbits, where after the descemet membrane was removed, there was intense corneal edema, as can be seen in the left-hand picture, followed by implantation of this endoart or artificial implant, which resulted in resolution of corneal edema after the implant was attached. So there is a risk of detachment because this is an artificial bioimplant, and how it is going to attach can also be a problem. And when we see in the porcine model with the attached endoart, the corneal edema reduces, but when the implant is detached, there's a significant edema as seen in the bottom picture. So following these animal experiments, we had the collaboration with the LVPI, and this was the phase 1 part of the investigation, which began somewhere in 2017-18 with our interest in this novel concept and device. So the phase 1 first in human investigation in India started after the DCGI approval was obtained, and this was in December 2019, and this was for 2 patients, and the device was to be implanted in patients with no or low or poor, no visual potential at all. So this is the first patient which was operated on in January 2021 and has a 2.4 years of follow-up. And the clinical details of this patient was a 55-year-old male who had prior failed DSEC, and there was optic neuropathy secondary to pseudoexfoliation glaucoma with pseudoaphacodonesis. So this patient underwent the surgery. The surgery is very similar to DSEC, where the first step is to remove the epithelium. The previous DSEC graft was removed with scoring. Subsequently, an inferior PI was created because the implant has to be adhered by means of a gas bubble. And the fourth picture shows the marking of the device. This is the previous phase 1 device, which came with 2 asymmetrical markings, which had to be done with a marker. And subsequently followed by implantation of the device in the correct orientation, followed by suturing and air gas tamponade. So this is a post-op day 1 picture, which was quite encouraging. And subsequently, we had the patient 2 who was operated in February, 1 month later. And this patient also now has 2.3 years of follow-up. This was again a patient of total glaucomatous optic atrophy with no visual potential, but was symptomatic because of bullae and pain because of the corneal decompensation. So subsequently, the patient did well, and the cornea is compact in the follow-up period. Further to this, after obtaining success in these 2 initial cases, the DCGI approved the phase 2 investigation, which was in December 2021, and this was with the improvised version of the previous device, and the 2 asymmetrical marks were changed with the F letter mark in the subsequent device. And this was to be implanted in the eyes with a good visual potential. So what is artificial endo implant? This comes by the trade name EndoArt. And this is a flexible dome-shaped implant with 6 to 8 millimeters diameter size of 50 microns thickness. It is a hydrophilic acrylic polymer of hydroxyethyl methyl methacrylate and methyl methacrylate, and this matches the posterior curvature of the cornea. So when we look at cornea, there are several complex machinery that keep the cornea functional and transparent. And the important one, which is recognized, is the pump leak hypothesis. This is the accepted physiological basis for stromal hydration control. We know that in endothelial diseases, cornea is more hydrated than its normal physiological state of 78%, resulting in loss of corneal transparency because of the corneal edema. The maintenance of the corneal hydration and homeostasis is an interplay of imbibition pressure, swelling pressure, and the intraocular pressure. So this device is based upon the concept of reducing the ingress of the fluid into the stroma and subsequently reducing the stromal imbibition. So it acts as a fluid barrier in the posterior stroma, causing a decrease in the aqueous inflow into the stroma and thereby reducing the corneal edema. So the surgical technique is pretty much similar to routine endothelial keratoplasty, and this is a video of the representative case. So initial followed by removal of the epithelium to enhance the visualization and marking the center area. So important point is to remove the Descemet's membrane. There should be no implant and DM, it should be completely devoid of the Descemet's membrane. Otherwise, there's a risk of detachment in that focal region. The Descemet's membrane is removed, and we should not be removing the complete Descemet's membrane also. Otherwise, in some patients, we can run a risk of having peripheral bullae. So DM is removed, and this is followed by implantation. Initially, a PI has to be created because the implant is to be attached by means of a gas bubble, which was 10% C3F8 in the second protocol. And this is the implant, which comes again in a sterile container. So it has to be inserted in the right appropriate manner. The F mark should be visibly seen, and as we manipulate the implant, we'll see that the F mark is in the right orientation. The implant can be touched because it is quite resilient. And this is the F mark, which we can see at the 5 o'clock location from the surgeon's view. This is followed by suturing the side post because we don't want the gas to leak out, and tamponade is really important, and the patient has to lie supine. As per the protocol, it was 4 hours, but it was a little hard to maintain. So we simply had most patients stay in supine posture for 1 hour to 2 hours. Sometimes there can be interface gas bubbles which have to be removed, otherwise there will be the sites of detachment. So this is from the phase 2, some representative cases which have completed 1 year plus follow-up. This is a phase 2 patient which was operated on 29th March last year. And this was for persistent corneal edema post-complicated cataract surgery with medically controlled secondary glaucoma. And this patient post-op day 1 and 7 months later, the patient's vision recovered quite well in 2 and 3 months follow-up, and was 20/30 at 7 months, and 14 months is maintaining the same vision. He subsequently had a raised pressure which was managed with trap, but his vision maintained throughout the post-op period. This was another patient who had pseudophakic corneal edema and had 2200 vision. The other eye was normal. Following the surgery, there was a good visual recovery. So the gas bubble is, once the resolution of gas bubble happens, the sutures can be removed. And this patient, following corneal clearing, underwent a YAG capsulotomy, which restored his vision in 2040. And this we can see the pre and post of OCT of the same patient. So 8 months when we do the refraction comes to a little bit of a hyperopic error in a few patients. And this is the post-op follow-up, and this patient also has now completed 12 months follow-up. So I experienced in the 12 eyes, 2 non-seeing and 10 eyes with visual potential. These were the cases, these were varying cases of pseudophakic corneal edema in all patients, and TAS-like features were present in 5. Haptic was an AC in 1 eye. So these were the spectrum of the cases which were managed with this procedure. So the experience has been there was device detachments noticed in 4. 3 it was partial, and 1 it was a dislocation. We bubbled in all 4 of them with air bubble. The phase 1, it was safe and effective in relieving the symptoms of discomfort in the follow-up period up to 2.4 years. In the phase 2, it was safe and effective in visual rehabilitation 9 out of 10 eyes. There were no serious adverse events. 1 eye did have a hypotony, which was probably related to, in the hindsight, related to a cyclodialysis cleft post prior complicated cataract surgery. 1 eye developed HSV stromal keratitis at 3 months after initial recovery. 1 eye had raised IOP noted at 1 year and required TRAB, following which IOP was in good control and visual acuity was maintained throughout. The BCV in 10 eyes with visual potential, 1 patient achieved 20/25, 1 patient had 20/30. In 6 patients, the visual acuity ranged between 20/100 to 20/60. Hypotony was noted in 1 patient. 1 patient had a retro implant membrane because of this patient also had a TAS. So whether it was sort of related to the prior condition, that's what was thought of in the hindsight, because it was not related to anything else with the same implant implanted in other patients, and TAS because of the implant itself had to be ruled out. So what are the merits of artificial endothelial implant compared to human donor cornea? This does not require steroid medication for long because of its non-biological nature. There's an ease of intraocular manipulation without risk of damaging the implant. There will be no waiting list, and it can be stored for years before use, just like IO devices. So hence, this option may make it viable option in the management of corneal decompensation in uncertain times, what we face in the pandemic. And the study also happened to be during the pandemic times, and where there are places of shortage of donor corneas. The current status of endoimplant surgery, and this is multicenter data from Israel, India, Netherlands, Georgia, and Singapore. This has been tested in 120 plus eyes so far. Long-term follow-up of 4 years is available. The longest follow-up is from Netherlands. IOP interpretation with the implant in place is fairly reliable with Goldman's applanation. Since the device is based upon biophysiological principle, the visual acuity, I presume, can vary in relation to time of the day and IOP. And attachment of the device can be somewhat more challenging than EK intuitively. There are finite perfections may be needed because the implant sizing has to be with respect to the posterior corneal surface area, which will vary in individuals. And this is to address the peripheral bullae which can occur, which was noticed in some patients in the follow-up period. So what is the regulatory status of this implant? As of now, the EndoArt is NMPA, FDA, and CE approved. These are all European and US, but it is also approved by the DCGI. Approval has been sought last year, and probably it will be available in market for use in this year, somewhere in the second half. This is what the data comes from the regulatory offices. So potential applications could be cases of fugues with an alternate, where this could serve as an alternative to DSO, DWEK, DSEC, and DMEC. Glaucoma eyes with drainage devices, failed multiple PKs due to rejection episodes, steroid responders, and those refusing biological tissues, also as an alternative to ASP non-seeing eyes. It may not replace the conventional surgery, but it may be an adjuvant or an option in many of these conditions. So my acknowledgements to the ION team and Dr. Offer Daphna specifically because he's the innovator and the corneal surgeon for this device, and Dr. Eri, he's a corneal surgeon based in Israel, and Nahum Ferreira, who's a CEO and team member. Dr. Prashant Garg, who was my co-PI in the first study, and all my Cornea faculty members, my clinical research team, and our regulatory compliance partners, Mala and Rifat. And of course, last but not the least, our patients who had trust in the services all throughout. Thank you very much.
Yeah, that was an excellent work and a great presentation. Do anyone has any queries?
So device reduces the imbibition of fluid, the aqueous humor, into the stroma. So thereby the relative hydration of the cornea is sort of maintained. Like when it is a impermeable device. Normally you have the cornea which is 78% hydrated. So if you can reduce, like in corneal edema, what is happening when the endothelium is not functioning? You have increased fluid in the stroma. So if you can limit this imbibition of the fluid, you will be still able to achieve 78% of detergescence. So that's the concept on avoiding the need of the endothelium by just making it an impermeable barrier. Not cutting off the nutrition per se, but in a limited way to match the nature's natural state of hydration of 78%.
I have a question like so I know this I had discussed with you long time back. So what will be the approximate cost of this? Do you have any guess?
There was some discussion on this, and just to understand, because I think for every product to launch in the market, they have to understand what the conventional cost of the surgery is. So all that has been discussed with them. What the cost will be, I'm not sure, though I have just given my perspective on how adoptable it will be in the clinical practice, and because they have to look into account the category of the patients, they have to look into account what is the advantage over the conventional and what is the current treatment cost for DSEC, DMEC as an option.
Yeah, one more question. Do you do a peripheral corneal scoring to make the attachment better, because the detachment rates are slightly more compared to DSEC, right?
Actually, the stroma should be as smooth as possible, and but Descemet's membrane should not be there, because in the phase 1, it was said that we can't remove the Descemet's membrane, but the detachment rates were way higher. Though we didn't encounter detachments here with our patients, but in the multicentric data, it came out like that could be a factor for detachment. We still have to see that. So in the phase 2, it was said that you remove the Descemet's membrane, the adhesion will be faster, probably based upon the data from other countries and also from the animals experiments. So in the second part, it was advised to remove the Descemet's membrane, which was not in the first phase 1 trial. But it was also emphasized that it should be completely smooth and not too much of scoring, scraping of the stroma should be avoided. Otherwise, that place forms a barrier for attachment of the implant.
How does it behave in silicon filled dyes, silicon oil filled dyes? Because we know that other grafts fail.
Yeah. I think in future it might be because this was a very controlled one which had to be implanted in pseudophakic eyes with specific no VR
Yes,
surgery because so there were a lot of a huge list of contraindications and exclusion criteria in the second one.
Okay. Yeah. Thank you. Thank you, Sunita. Nice
Yeah, thank you.
presentation.
We now move on to the next talk by Dr. Radhika Tandon on success stories in iBanking.
Good morning, everyone. Thank you for the opportunity to present in this symposium. I would say the success stories in iBank, the entire story of iBanking in India is a success story. As we stand today, we are the country second only to USA in the amount of corneas that are harvested and transplanted. And I see no reason why we cannot overtake that if everybody works in a concerted effort. I'll just give you a few snapshots of success stories from our own experience. We have the National Eye Bank at RP Center, AIMS. It is a government-funded eye bank. We have the director and the chief RP Center, and then we have a chairman, co-chairman, and an officer in charge. And of course, there's staff infrastructure and government funding. When you look at the numbers, they may seem small compared to some other institutions, but generally over the years, the iBank has gone from strength to strength, and it has been a cornerstone in training and teaching and providing human resources in the field. And consistently, we have maintained a utilization rate of more than 70%, and largely it is about 84 to 85%. And as Radhika, my co-name person over here, mentioned, we really need to think about making it 100% because there are eye banks who have 100% utilization, excluding only the corneas which have a definite contraindication like serology positive. So I'll just give you a few snapshots of some small success stories. Of course, you all know that the COVID pandemic led to many challenges, and apart from the first phase when everything completely stopped and then gradually everybody picked up, looking at Delhi where we had our Omicron wave in say December. So by the time we had picked up and started reaching our monthly collection of about a collection of 80 and say utilization of 70, then as the in December when the Omicron wave was starting, it was about still 83, 80. And then suddenly in January when the Omicron wave was fully in place, there was a marked decrease in the collection and utilization because there were a lot of patients who were under contraindication. Similarly, then in February, etc., it picked up and then went back to our total monthly collection of about 94 by March. So this is just an example of how we had these phases, and then we would like to appreciate the way the entire iBank staff and the entire infrastructure sort of adapted to the situation and move forward. Then we also noticed that we had an increase in our multi-organ donors. We had a very dynamic professor from the Department of Neurosurgery who's now posted in Trauma Center, and he personally was counseling the brain dead families. I mean, families of the brain dead patients in ICU. And you all know that there's a required request, legally required for ICU deaths. And he personally would counsel them, but he just told me that there were several multi-organ donors, like out of 8 in a year, there were 3 who had refused for eye donation when they had agreed for every other organ. So this was a little bit of a challenge, and when we spoke to the counselors and the coordinators, there was a lot of concern about disfigurement because all the other organs are within the body, and this is the one which is external, and they had to go long distances to the village, and they said in the village we have to go long distance, and they will say that you have led to disfigurement. And the neurosurgeon himself was not aware that there is no disfigurement. So he said, can you give me some pictures? I said, you can. He said, no, you give me some pictures because I personally talked to them and I spent several days of counseling. So you must give me some pictures. So I told the counselors that you only, whenever you take the, when you do the normal autopsy or the cadaver or post-mortem donations, you only take the picture because there's no point me giving an artificial picture. So you take the picture before and after. And then this, we gave it to him in the small poster, and then he started using this for counseling, and then those refusals started reducing. And of course, we required, because you see, in a government setup, there is a changing population. You have residents, nurses, staff, and they all change from one department to the other. And you have to keep, there's a totally new team which comes, and each person has to continually be motivated. So we have to continue our motivation and promotion activities using cycle rallies and running, etc., involving the AIMS campus itself. And if you see, every year after the COVID pandemic, so the first year after the COVID pandemic, the annual figure was 750. In 2022, it was double that. Now focusing on the factor of non-utilization of corneas. So here again, we found that according to me, every HCRP cornea should be a utilizable cornea. And suddenly I found that a lot of HCRP corneas were actually being considered as non-optical grade. They were being used for therapeutic cases, but as far as I'm concerned, they should have all been optical grade. So I told them that and sometimes you'd have a young donor, say 30-year-old, 35-year-old, and the cornea was being graded as non-optical. So then I said, let's plug what's happening there. So there were some of them having long death recovery time, and the person grading would use that as a sort of a psychological criteria. So I said, no, there's no psychology involved. You have to consider that as an independent factor in determining the utilization, but you have to grade the cornea based on its anatomical and functional properties. So with that, we were able to, rechange and retrain the staff, and there's so many good people working, but I just like to highlight a few of the personnel. So we have this technician who would specifically take part in the cultural events organized by AIMS, so that he would develop a network with the entire technical staff. Similarly, we have this eye donation counselor. Earlier, we depended on external support organizations to support our eye donation counselors or grief counselors via projects. But over the years, there was a restriction on this because of the health ministry guidelines and also FCRA considerations, that the organizations were not able to meet the requirements and provide the funding. So we had created a post of patient care coordinators, which is a well accepted cadre in the government setup, and we were able to get our patient care counselor, our eye donation counselors incorporated under the cadre of patient care coordinators. And one of them, I'm just giving you one example, who has been very consistent in getting good quality corneas. And then of course we have a scientist and we have a nurse coordinator. And then also we found that a lot of these eye donation counselors were on their own saying that this is not suitable, not suitable, not suitable. And the technicians also were saying not suitable, because they were reading all the things from the NPCB guidelines, which is a guideline, but you have to take the consultation of the medical professional who is the doctor on duty. So we realized that they were wrongly, saying it's a contraindication, not even approaching the family. So we made it very simple. Who can donate? Anyone and everyone, except serology positive or hepatitis, known hepatitis, and active sepsis. And I said, you don't decide active sepsis based on the TLC report. You will consult the doctor concerned. That is an active sepsis. And then similarly, leukemia, lymphoma, eye tumors, and Alzheimer's, dementia, Parkinson's, and CGDs. This was just for the purpose of the counselors, so that they would and if they had any doubt, they would then consult the doctor on duty. And then of course we have the entire RPC family, which has always been supportive to the eye banking facilities that we have. So impact on keratoplasty, we started having pediatric donors, and here again the neurosurgeon sent me a message that we had this 4-year-old donor. Can I know who were the recipients? And when I checked up, the recipients actually, they had been used in elderly people. One was a 30-year-old and one was a 50-year-old. So that was a bit unfortunate, because we have so many children waiting. It was just a question because the ecosystem was not geared to thinking that way. So therefore, we make sure that the recipient is of a child, a donor is a recipient is also a child. And sometimes it happens that with children it's challenging. changing. Either they get URI on the day of the surgery or something like that. So we always have to have 5 to 10 children ready as a backup. So here are a few examples. Peter's anomaly, the donor here was, in this case was a 25-year-old. This was a 7-month-old and a 7-year-old recipient, a 7-month-old recipient, 7-year-old donor. Here we have a 3-year-old donor, 8-year-old recipient. So we try as far as possible. And we've had very good results. A 1.5-year-old child with sclerocornea, traditionally supposed to have very poor prognosis, but on careful follow-up, and then by showing these pictures to the counselors and also this neurosurgical team, we're now having many, many younger donors, as young as 1.5-year-old. Now, we do know that less than 3 years old is generally considered as a contraindication, but if you have recipients who are the similar age group, so as I said, there's no blanket contraindication. Generally, we do take 3 to 75, but if you have recipients who are younger, you can. And then again, so this is one little girl who's had both eyes operated now, and we sort of had to, we still have a large number of patients waiting for keratoplasty. There's still not 330 children, but it's not necessary that it's entirely because of lack of tissue. Sometimes the children also have raised intraocular pressure, and then they have repeated surgeries, and they may not be fit at the time of surgery. So patients with complete blindness also do have to wait. So this was that 4-year-old donor whose eyes were donated. They were transplanted into adults who did very well, and but in future it sensitized us that we need to get the whole team in a very large organization where there are many people taking the decisions, and it's a question of allotting the cornea. It is also goes according to the waiting list, but you have to take other considerations. It's not simple mathematics. And so with that, I'll just want to say that these are the few small successes I'll say, but I wanted to share these experiences. Yeah, thank you.
Thank you, madam. Speechless. I don't know what to say.
All right.
I mean, all of us face the difficulties of availability of tissue, and many a times eye banks which we are associated with do get tissues, but then the quality is so poor that we cannot use it. So as you said, yes, we have to have ways of increasing the availability of tissues which can be utilized more.
One question about corneas which cannot be used, I think you should put them in glycerine. And honestly, this decellularization, we do not have to go to pig sources. We do not have to go to international sources. Within our country itself, we have decellularization protocols, and these corneas can be used for lamellar grafts. So we have one approved clinical trial now. We've done the animal studies where the human cornea, which is not suitable because that cornea can even be autoclaved when it's decellularized, just like vision graft. Now, vision graft, they don't share how they make it so transparent. That is something in the process which we are working on. But you see, these corneas, you decellularize them, and then you can use them for lamellar grafts. And growing the endothelium is difficult. So that is definitely a challenge.
Very true. And eagerly waiting for the outcome.
Yeah, hopefully. Then we will be able to use more corneas from everywhere. But please put them in glycerine. Because it's a very good option. And even for patch grafts, you can, because you feel good at least that the donor family who has given that donation, the cornea is used, it makes a difference. Yeah.
Ma'am, have you seen that the glycerin preserved corneas, which are white and thick, they clear over a period of time if it is used?
Yes. So with the glycerine preserved corneas, firstly, you cannot use it for a full graft. So you have to use it where at least there's some peripheral rim of corneal tissue. That's number one. So if you use it for lamellar graft, they can clear up. There are many publications from Brazil of DALC using glycerine preserved corneas. That's one. Secondly is when you're implanting them, wash them thoroughly, irrigate them nicely to get rid of all the glycerine, and they may not become transparent, but they can have a tectonic role. And the third thing is that like in tissues like DALC, if you properly select the case and don't go right up to the limbus, then gradually the glycerine preserved, because you see the stroma is fine. The only thing is there's no functioning endothelium. So they can clear up. There are many, but the only thing is we don't need to use glycerin preserve for DALC because we have a lot of non-optical tissue, fresh, which we can use for DALC. So from that point of view, I feel the glycerin preserve corneas, the main benefit is patch grafts and emergency surgeries. And then later, if our decellularization and all that, if we're able to show, then maybe you can use it. Yes.
Thank you, madam.
Thank you.
So now next we have Dr. Geeta, who's going to give the next update on ocular surface.
A very good morning to one and all of you. I think what I'm going to do is over the next few minutes give a brief update of what has happened in the field of ocular surface and what is new in the field of ocular surface. It's not moving forward. Yeah, so the update will cut across disease pathophysiology, newer diagnostics, innovations, and management of ocular surface diseases, including Stevens-Johnson syndrome, OCP or MMP, dry eye, and chemical injuries. So the last couple of decades saw a lot of insight and understanding into Stevens-Johnson syndrome, and we were able to zero in on lid margin keratinization as one of the major issues that causes ocular surface deterioration in these eyes. And we were also able to understand the role of mucous membrane grafting in addressing lid margin keratinization in these eyes, which significantly reduces the blink-induced microtrauma. And this has now been credited with a window of opportunity in these patients of SJS, where it can actually help stall the deterioration in the ocular surface. Also, we today understand the need for a comprehensive approach to patients with chronic ocular sequelae of SJS, which is broadly categorized under procedures that help to stabilize the ocular surface, tectonic procedures, and visual rehabilitative procedures that range from optical iridectomy to cataract extraction to the different types of keratoprosthesis. In the last 25 years, we have seen a paradigm shift in the management of patients with SJS, where several newer management modalities have helped significantly improve the outcome in these patients that otherwise used to have a significantly downhill course. The white spots which had eluded us for quite long are now recognized as ectopic sebaceous glands of Gibson along the lid margin, which fortunately do not have a significant role in causing any harmful effect to the ocular surface, but they can be triggered by the inflammation that occurs in Stevens-Johnson syndrome. We've also tried to understand the pathophysiology of the disease by conducting various cytokine studies in the tear film of these patients in an area where there is a significant paucity of literature, because ultimately, as we all understand, unless we do not know the pathophysiology or identify the biomarkers in these patients, targeted therapy is going to be difficult. And this was one of the hallmark publication under the lead authorship of Professor James Chodosh, where several key specialists from India were part of this particular paper, where we identified the windows of opportunity which are now considered as mandatory roles for ophthalmologists in the management of the acute as well as the chronic stage of Stevens-Johnson syndrome. Simultaneously, chemical injuries also saw a significant revolution in the management of the chronic stage in the form of simple limbal epithelial transplantation, or SLET, where we moved away from the laboratory and transitioned from ex vivo limbal stem cell transplant to SLET with very good outcomes. And today we know that the decision making for both limbal as well as corneal reconstruction in these eyes has a very specific algorithmic approach that have been provided by various groups, which more or less are quite similar, whether it be bilateral limbal stem cell deficiency, where the key decision is to decide between the need for a keratoprosthesis or limbal stem cell transplant techniques, which in this situation would require systemic immunosuppression, or in unilateral limbal stem cell deficiency, where usually the algorithmic approach is quite straightforward and largely depends on limbal stem cell transplantation. What we have also realized that in these eyes with both bilateral as well as unilateral limbal stem cell deficiency, if we are able to achieve a moist surface or retain a moist surface, retain the well-formed fornices with the normal corneal thickness and clarity of the cornea, these are the eyes that have the best outcome. And in very severe grade acute chemical injuries, one of the means to achieve a good outcome by appropriate management in the acute stage has been the role of alloslet in the acute stage of chemical injury, which has significantly helped us to rehabilitate these patients subsequently in the chronic stage with a good outcome. The comparisons between alloslet and just amniotic membrane in severe grade injuries has definitely revealed a beneficial role of alloslet in these eyes, which was based upon our understanding of the pathophysiology in the acute stage of chemical injury, which primarily revolved around what we today term as the I's and E's in the management of acute chemical injury, which formed the basis for us to have proposed what we call as an enhanced grading for acute ocular chemical burns, or EPICS, which is an acronym that stands for epithelial changes, pressure, ischemia, and exposure, all of which are parameters that need to be mandatorily addressed in the acute stage of chemical injury in order to have a good outcome in these eyes. Alloslet does not have a role to play just in chemical injuries or limbal stem cell deficiency, but also in ocular surface tumors, especially the large ones that involves a diffuse aspect of the cornea, or the giant OSSNs, where these patients can end up with a limbal stem cell deficiency postoperatively, and alloslet has had a role in reducing the occurrence of LSCD as well as the risk of symblepharon that we see in these patients otherwise. An important topic in OSD, of course, is dry eye, and no talk will be complete without an update on dry eye management in these eyes. Today, we know that we have a gamut of investigations as far as dry eye disease is concerned, and all of them do have a role to play in the diagnosis of the different types of dry eye, especially the meibomian gland dysfunction and the equistia deficiency. We do have recently approved new treatment options for dry eye, though artificial tear substitutes still continue to remain the mainstay of treatment in these patients. And it's important to understand that amidst the availability of all these modalities, it is important to identify the logic amidst the chaos, and there is a need for a workflow in these patients which can be a uniform platform amongst all ophthalmologists, including specialists as well as general ophthalmologists, which is what we proposed by formulating what is called as the dry eye module, an application intelligence platform for diagnosing and monitoring dry eye disease, which is available for use by all specialists as well as cornea specialists and general ophthalmologists. And this is a very brief video that shows what the module does. Can we have the video, please? Yeah, so basically it gives you a diagnostic sheet once you enter the examination findings. It also produces a cornea rheumat interface sheet, a customized letter for the rheumatologists, and it forms a very useful tool where all of us can talk the same language as far as identifying the parameters and diagnosing the dry disease is concerned. And I would like to end by talking about the field of keratoprosthesis, which forms the last resort for end stage ocular surface disorders. One of the options that we have today is the Boston type 1 keratoprosthesis. This was our first patient of Boston type 1 that we did for an oil filled eye way back in January 2008, which is when the type 1 KPRO was initiated in several institutes across the country. And this patient today has a 15-year follow-up, maintaining a vision of 636 in her only eye. And we've only learned over the journey about the nuances of keratoprosthesis in these patients, and this was one of our very early osteoodontokeratoprosthesis patient, a 10-year-old child of SJS who had been following up with us since 1995, underwent the procedure of MOKP in 2005, and today 18 years later continues to maintain a vision of 6.6 and 6, which was something that was unheard of way back then. This is a panel of the different types of keratoprosthesis that is currently available, and at Shankar Nethralaya we have all the different types of keratoprosthesis as well as limbal transplant techniques that can be provided under one roof, which helps us customize and tailor the management for every individual patient. This is one article that I would like to draw your attention to, which in a very simple manner provides all the information that is required about the different types of keratoprosthesis, the indications, the techniques, and the complications related to each of these. So to conclude, ocular surface disorders has been a significant area of specialty under the broad umbrella of cornea and external disease, a niche area of focus which has grown significantly by leaps and bounds in the last couple of decades. It involves the use of technology for patient care. A lot of passion and drive is required to follow this subspecialty. Definitely needs training and a huge teamwork that goes into it, and a lot of perseverance, and like I mentioned, patience as well as passion to take up this as an area of focus. We have a 3-month short-term ocular surface fellowship for anyone who might be interested after completing your cornea fellowship. And for those who might want to have a taste of what ocular surface diseases and its management entails, we have the OSCON 2023 coming up in August, the end of August, that deals with ocular surface disorders and keratoprosthesis. And I invite all of you to our upcoming Keracon in Chandigarh this year. Thank you.
Thank you, Dr. Geeta. That was a brief, excellent overview of the voluminous work that you guys are doing in your esteemed center. Not many people really realize that in the non-Western world, we have this option. Our country has the luxury of offering such advanced ocular surface work, which is very, very unapproachable in a lot of other Asian countries. We close the session? Yeah. No, we have completed the session now, and if somebody would like to make a comment, welcome. Yeah. Yeah. Do we have time? Yeah, ocular surface. Geeta, somebody wants to see the video of.
Yeah, it was running when we checked it in the preview room. I don't have it in a separate file, but I can share the link probably after the meeting is over. Thank you.
If there are no more questions, comments, I think we'll wind up the session. Thank you.